Hi guys, welcome to today's MCQ discussion, MCQ discussion number 22. So let's get started with the first question. An 84-year-old man presents to you with loss of weight, loss of appetite, chronic fatigue, and cough with blood in the expectoration. Chest x-ray was done and is as shown below. What is the diagnosis? A. Oat cell carcinoma. B. Bronchogenic carcinoma. C. Mesothelioma. Or D. Lung metastasis. So pause, think, and then we will discuss. So here, from the history level, you have an elderly man who comes with loss of weight, loss of appetite, chronic fatigue, and some hemoptysis. So from the history level, definitely looks like a malignancy, probably a lung malignancy. So he had a chest x-ray done and the x-ray is as shown below. What is the diagnosis? So this x-ray is very high yield. This image is very high yield. Okay, this is a typical x-ray showing well rounded opacities in both lungs, and this typical x-ray is that of cannonball metastasis. So the answer here is D, lung metastasis. So this x-ray shows you cannonball metastasis. So the answer is D, lung metastasis. So lung metastasis mainly presents with the said features of the primary malignancy and also with hemoptysis and sometimes even breathlessness. So this is a typical history. More than the history, the image is typical for cannonball metastasis seen in, or it's a type of lung metastasis. So that was about cannonball metastasis. Let's look at a few more images and talk about where all we see it. So cannonball metastasis is a type of pulmonary metastasis in which you have rounded nodules, usually well circumscribed rounded nodules of variable size that are scattered through both the lungs, and this indicates a hematogenous spread of a primary malignancy. So usually it's seen with sarcomas, because we remember from patho that sarcomas usually spread hematogenously, that is via blood, and carcinomas usually spread via the lymphatic system. So pulmonary metastasis or cannonball metastasis, you see well rounded nodules of variable size scattered in both lungs, and it spreads via the, or it comes to the lung via the hematogenous route. Let's look at the images. So this is a cannonball, okay, well rounded. So here you have an x-ray which shows well rounded images. Then you have your CT scans again which show multiple well rounded images on, or well rounded masses, on both sides. Again CT scan. So HRCT is the best diagnosis. So another CT scan showing multiple masses on both sides, and here you have a gross specimen of the lung, again showing your cannonball mets. So cannonball mets, very high yield image. That's why I've taken a little time for that. Also, the common primaries that metastasize to the lung include the renal cell carcinoma, carcinoma breast, colorectal carcinoma, uterine leiomyosarcoma, other sarcomas too, choriocarcinoma, very important, and even head and neck squamous cell carcinoma. So the very important ones for cannonball mets, remember, renal cell carcinoma, CA breast, and even choriocarcinoma, especially if you see some gynecological history with cannonball mets or some gynecological history with breathlessness, you should always think of choriocarcinoma and also uterine leiomyosarcoma. So these are few important primaries that cause lung metastasis, particularly cannonball metastasis. So let's move to the next question for today. So question number 2, a 32-year-old lady presents with constant fatigue and lightheadedness since the past 6 weeks. On evaluation, her hemoglobin was found to be 8 gram per deciliter, and she was also found to have raised indirect bilirubin levels. Peripheral smear is as shown below. Which of the following is most likely to be raised? A. LDH1, B. LDH2, C. LDH3, or D. LDH4. So pause, think, and then we will discuss. So here you have a lady, fairly young, who comes with constant fatigue and lightheadedness, and a low hemoglobin. So now we are definitely sure that it's some kind of anemia. And then you also have raised indirect bilirubin, okay, which is indicative of some hemolysis. So remember, if you have a raised indirect bilirubin, it indicates some pre-hepatic cause of jaundice, or usually indicates a pre-hepatic cause of jaundice, which is usually some kind of hemolysis. So here we have a hemolytic anemia, or we are suspecting a hemolytic anemia. And then you have the picture of the peripheral blood smear, which shows some broken RBC fragments. Okay, so schistocytes, so some broken RBC fragments, very clearly seen. So we are sure that this is a hemolytic anemia. So the question is, which of the following is raised in a hemolytic anemia? LDH 1, 2, 3 or 4. So to understand this, or to answer this, we need to know a little bit about the LDH enzyme, which is the lactate dehydrogenase enzyme, and more importantly the isoenzymes associated. So let's talk about the isoenzymes of LDH. So there are 5 important isoenzymes: LDH1, LDH2, LDH3, LDH4 and LDH5. So LDH1 is primarily found in the heart, cardiac myocytes. LDH2 is primarily found in the blood, mainly in the RBCs. LDH3 is seen in the brain, kidney, lungs, spleen and pancreas. LDH4 and 5 both mainly seen in the liver and skeletal muscles. Okay, so out of all these, the 2 important ones are LDH1 and LDH2, and I've marked it here too. So LDH1 and LDH2 are the important ones. And remember, LDH1 is seen in the heart, so LDH1 is the heart LDH, and LDH2 is seen mainly in the blood. Now let's talk about a few high yield points from LDH. So the first 2 I talk about are super high yield, and the next 2 not so high yield. So the most important point to remember is that normally LDH2 is greater than LDH1. So in blood, normally we have more amount of LDH2 than LDH1, because like I said, it is the blood LDH. So normally LDH2 is more than LDH1, but in case of myocardial infarction or some ischemia of the heart tissue or the cardiocytes, you have an increased LDH1 compared to LDH2. So LDH1 raises compared to LDH2, because like I said, LDH1 is the heart LDH. So remember that when there is ischemia, the heart cells die and they release LDH1 into the blood, and it's an indicator of MI. So this is called the flipped LDH pattern, or the reversal of LDH pattern. So normally 2 greater than 1, but if 1 greater than 2, it could indicate MI, or usually indicates MI. Okay, so because now troponins have come into play, this is not so relevant or not so used, but can be asked in the exam. So reversal of LDH or flipping of LDH. So way to remember this, to never forget, is that 2 is normally larger than 1 numerically. As a number, 2 is bigger than 1, right? So similarly, normally, since 2 is normally bigger than 1, normally LDH2 is also more than LDH1. Now let's go to the second point, which states that LDH2 is raised in hemolytic anemia. So in hemolytic anemias, remember LDH2 is the blood or the RBC LDH, and when there is hemolysis, there is a raising of LDH2, or LDH2 levels go up. Next 2 points: LDH3 is seen increased in metastasis, usually of the brain, kidney or lung. So lung and brain metastasis usually present with increased LDH3. Sometimes pneumonia, lymphomas and ALL. And LDH4 and 5, like we said, they are found in the liver and skeletal muscle. So a raised LDH4 and 5 are seen in hepatic diseases and even in muscle dystrophies, okay, because it was mainly found in the liver and skeletal muscle. So going back to the question here, we diagnosed it to be a hemolytic anemia based on all the things given, and the question was, what is raised in hemolytic anemia? So remember, LDH2 is the blood LDH or the RBC LDH, and it's raised in hemolysis. So the answer here was B. Okay, now let's go to question number 3. FAD is a coenzyme derived from A, vitamin B1, B, vitamin B2, C, vitamin B6, or D, vitamin B7. So coenzymes and vitamin coenzymes are very, very, very high yield, so you should know this. So straightforward answer though. So the answer here is B, vitamin B2. FAD is derived from vitamin B2. But because this is such a high yield topic, let's discuss a little bit about it. Just give me a second. So it's very high yield, so we'll discuss a bit about each of the important B vitamins or the important vitamin Bs and the coenzymes associated with them. Also the reactions these coenzymes are involved in. So very important, very high yield. So firstly, vitamin B1 is called thiamine, right? And the coenzyme is thiamine pyrophosphate. It's a coenzyme or plays a role in decarboxylation reactions and trans-ketolase reactions. Riboflavin is vitamin B2. Its coenzyme form is FAD, flavin adenine dinucleotide, and it plays an important role in hydrogen transfer reactions, particularly the dehydrogenase enzymes. So remember, FAD2 plays a role in succinate dehydrogenase of the TCA cycle, acyl-CoA dehydrogenase, which plays a role in fatty acid oxidation, and also in the enzyme xanthine oxidase. So riboflavin, FAD, hydrogen transfer. Niacin gives rise to NAD+, which is nicotinamide adenine dinucleotide. So NAD+, again, plays a role in all hydrogen transfer reactions. So it's part of, or it's a coenzyme for all other dehydrogenate enzymes other than what I mentioned for FAD. Next you have vitamin B5, right? B5, which is pantothenic acid, which gives the coenzyme A, which plays a role in transfer of acyl groups, or it has a role, it's a coenzyme for the acyl group transferase enzymes. Then you have pyridoxine, which is vitamin B6. Its coenzyme form is pyridoxal phosphate, PLP in short, and this is the coenzyme for all your transamination reactions. Very, very important. All transamination reactions or transamination reactions have B6 as a coenzyme. They also play a role in decarboxylation reactions, few decarboxylation reactions. Now biotin is vitamin B7. Its coenzyme form, also called biotin, is the only enzyme which is a coenzyme, or the only vitamin which acts in carboxylation reaction. So remember, although B1 and B6 were part of decarboxylation, biotin is part of carboxylation reactions. So 1 and 6 is decarboxylation, whereas 7 is carboxylation. Very important. Folic acid, coenzyme form is THFA, tetrahydrofolic acid or tetrahydrofolate. It is a methyl donor enzyme. We saw where it's used in the previous MCQ discussions. Cobalamin is B12. Two coenzyme forms, methylcobalamin and adenosylcobalamin, and they play a role in methionine synthesis and also in methylmalonyl-CoA transferase enzyme. So those were about the vitamins, their coenzymes or the coenzymes derived from them, and the reactions they are involved in. Remember, thiamine decarboxylation, TPP rather, decarboxylation, and B6 also plays a role in few decarboxylation reactions. Most importantly, B6 is associated with transamination reactions, very, very high yield. FAD and NAD, that is 2 and 3 in hydrogen transfer reactions. B7, only enzyme involved in carboxylation reactions. And B9 is a methyl donor. So FAD was from vitamin B2. Okay, B1 gave rise to TPP, thiamine pyrophosphate. B6 gave rise to PLP, and B7 was biotin. So we know a little bit about that. And this is very, very high yield, so you guys should go back and read it. Next, and the last question for today. A 30-year-old man presents with dyspnea and altered consciousness. He is a known asthmatic. Which of the following is most likely to be present in this patient? A. Metabolic acidosis. B. Metabolic alkalosis. C. Respiratory acidosis. Or D. Respiratory alkalosis. So very easy question, very straightforward. Pause, think, and then we will discuss. So here basically you have a person who's come with breathlessness and altered consciousness, known case of asthma, probably having an asthmatic attack or post an asthmatic attack. So in asthma, which of the following acid-base abnormalities are commonly seen? So remember, the answer here is C. Okay, it's respiratory acidosis. Obviously you can rule out metabolic because we know asthma is respiratory, so metabolic is ruled out. So you're really just choosing between C and D here. So remember, in asthma you see respiratory acidosis. So these are the causes of respiratory acidosis. But before I go into it, I want you to remember just one point, because whenever people say acidosis and alkalosis, they are always confused. So remember, when there is a CO2 buildup, okay, there is a rise in CO2, you have acidosis, okay, you have acidosis. To be more specific, respiratory acidosis. So any condition where you have an increased CO2, obviously, which means you will have an increased PCO2, you will have respiratory acidosis. And where do you have increased CO2? When there is reduced expiration. So any condition where there is some obstruction to respiration, like your obstructive airway diseases or COPDs basically, or there is some difficulty in expiration, either due to muscle activity or reduced muscle activity, reduced respiratory activity, or some central nervous system involvement. Whenever there is reduced CO2 excretion or CO2 exhalation, you have acidosis. So in short, remember, CO2 equals acid. Remember, carbon dioxide is an acid. Just remember it like that. So CO2 acid. Whenever CO2 increases, acid also increases. So increased CO2 leads to respiratory acidosis. So causes of respiratory acidosis, any condition where there is reduced expiration, basically CO2 buildup is there. So when PCO2 increases, you have acidosis. So very simple principle. So we know in asthma there is some obstruction, so there is reduced expiration. So obviously we'll have respiratory acidosis. Very easy. Remember this concept, CO2 acid. So the causes of respiratory acidosis could include central causes like stroke, again due to reduced respiration, and drugs like sedative, anesthetics, and morphine. Again, they reduce the respiratory rate. So there is hypoventilation and hypercapnia, which is increased CO2. Next, respiratory causes include COPD, again obstruction, so CO2 buildup, asthma, again CO2 buildup, pneumoconiosis, and also ARDS, acute respiratory distress syndrome or adult respiratory distress syndrome. Neuromuscular causes like myasthenia, kyphosis, poliomyelitis, and muscular dystrophy, and miscellaneous causes like obesity, hypoventilation, and hypercapnia. So anywhere there is hypoventilation and hypercapnia, you will have respiratory acidosis. CO2 equals acid. So that's it for today. We'll have a discussion in the coming days. Again, I'm sorry that this video has come out so late, and I don't think I'll be able to post videos every day from now on, because I'm starting my PG and things are a little busy. But whenever I can, I'll post these high yield MCQ discussions and few other high yield topics. So see you guys in the next video. Thank you.